All right, so one of the main things when you're working with spinal cord patients, it's challenging because a lot with rehab, we're so concerned with just trying to keep patients to where they kind of just cope with their condition. And, my opinion, I get patients that don't like to settle for what their diagnosis they've been given. They want to start moving, which is exciting. So in order to get that, you have to do a lot of different type of, therapies. So as you see right here, we have multiple neurosolution lasers. Right now we're using 5 lasers. We're going to be lasering an area in the back called the cerebellum, behind the ear. We're going to laser the spinal cord where the spinal pathway or the spinal cord injury is. We're going to be lasering on the legs where we're going to try and work on using some of our specific muscle weakness and paralysis settings to start improving blood flow and activate nerves. We're going to use microcurrent. We're going to use peripheral nerve stimulators. We're going to use neurosage. We're going to use hypervolt venom belt to start applying vibration in the back. And so what happens is when we start working with patients, a lot of times we use these peripheral nerve stimulators and we start putting inputs in, we don't get any type of contraction. And the goal is for us to be able to eventually not have to use this to get muscles, but what we'll do is we'll take like a peripheral nerve stimulator and then I'll go to a certain muscle group. I'm just try this and see here first. And then what I'll do is I'll come up in here. So he's already pretty sensitive now after being stimulated. But then we'll start trying to start shocking him and seeing if we can get muscle movement. And eventually what happens is we'll take this and we'll start dialing it down. And the goal is to get this thing as low as we possibly can where he can actually neurologically start to control his own foot. So that's kind of what helps us out with working with spinal cord patients. Why I've had such a huge success is that we're applying multiple sensory inputs at the same time for a sustained duration. And that's what gets the results. If not, and you can't just come in and just do 15, 20 minutes. It takes, up to hours. In our intensive program, we're doing 2 hours in the morning and 2 hours in the evening. And over that, sustained amount of time, we've been able to get to where now we can get muscles to really start to activate. So we'll take lasers and we'll put them over different settings. So again, for doctors that are watching, it's very important that the electrode placements are placed on specific areas. For example, where nerves come out and they bifurcate. We have this setting right here to try to help out what's called dorsiflexion and get the foot to start moving up. We'll put them on the inside of the leg right here to try to hit part of the dorsiflexion and also to hit the bottom of the foot. So me and Jenna here, that's what we're doing. We're using peripheral nerve stimulators on top of a microcurrent. We're also using TENS. We're using microcurrent glove, vibration, lasers, neurosage, and then we're using acoustic stimulation. And then a viplate. So all those multiple inputs are what's going to help out. So it's very important too. One thing that's very interesting, muscles move to rhythm. And so when you start using sound with muscles, it helps out. For example, when we work out, we like to listen to music when we work out. But when you start using specific frequencies or specific sounds, again, over a sustained duration, it can help out with activating muscles or improving muscle outcomes. I work with Parkinson's patients. I can take a Parkinson's patient, they're very shuffle on their feet, and then we'll use something like a metronome. We can start shocking. Let's start using a metronome, and it's a rhythmic movement, and then they'll start actually walking faster, which is pretty neat to see. Or we'll get like an infant who, can't walk or can't crawl, and we'll actually have them start, we'll kind of make them crawl to the beat, and then we'll get the infant to actually start moving. So it's just very important to be able to use like an audio-visual entrainment when you're working with muscle function. Yeah, that's pretty good. So what we're working right here is with a C7 spinal cord injury. And again, you're seeing a lot of kind of involuntary movements right now in the leg, but eventually what we're going to do towards the end of this week and start of next week, we're going to try to start working on being able to control these movements. So right now we're just applying a lot of sensory input to get these muscles activated. And then we're going to work on having the patient actually volitionally control these movements.